Thank you, everybody, for clocking in. I think we're going to start with our fourth Starleaf lecture of the month. It's a pleasure to introduce Professor Gareth Veal. He's a professor at Newcastle University and has a great interest and expertise in clinical pharmacology. And we've asked him to do a presentation to us today and give us an insight in the work that he's doing. Gareth, it's over to you.
Thank you, Frederik. Thank you for the invitation. So hopefully everyone can see the slides. So I work over in the Paul O'Gorman building, which is kind of situated between the front of the medical school and the North Terrace pub, which I believe is back open today, or for takeaway beer at least. So we work quite closely with colleagues at the RVI in terms of looking at dosing of childhood cancer patients and also centres around the UK. So the talk today is very much kind of cancer based, but there are certainly quite a few issues discussed which are relevant to lots of different specialties. So we know that in paediatrics, whether it's in paediatric oncology, and I'm sure it's the case for many other specialties, that there's no such thing as the perfect drug, where a drug benefits all patients, where a single dose is fine, where we get responses in all patients and we don't get adverse effects. With lots of the drugs we use in oncology are obviously very old-fashioned cytotoxic drugs. We've got some new drugs coming through, but most of the drugs are fairly nasty in terms of the side effects they cause. We know we need different doses for different patients. We're going to need different doses for a 2-week-old child as compared to a 16-year-old teenager, for example. And there's been, I think, lots of work, or a big buzzword in the last 5 years at least has been this idea of precision medicine or individualized treatment for patients. And this may be based on tumor biology or genetics, but from a pharmacology perspective, it's important not just to have the kind of right drug for the right patient, but also the right dose of the right drug for the right patient. And a good example of, I think, where clinical pharmacology has been shown to be beneficial is if we look at acute lymphoblastic leukemia, which is one of the big success stories in terms of the treatment of childhood cancer patients. And since the sort of like, certainly since the 70s, there's been massive improvements in treatment. We've now got up to kind of 75, 80 at least percent 5-year survival rates in these patients. But actually, we haven't actually introduced too many new drugs. We've basically understood the drugs better. We've got, we use clever combination therapies, and we've got a much better understanding of the right dose intensity to treat these children to get responses, whilst hopefully limiting some of the side effects. So I run a group, the Northern Cancer Centre Pharmacology group, over in the Paul O'Gorman building. We have kind of 3 main areas that we work on. One is early phase clinical trial work, which I'm only going to mention very briefly. This is new drugs. We either work with pharmaceutical companies or with Cancer Research UK to look at the pharmacology of new drugs. So when dose escalation studies are carried out, we carry out the pharmacokinetic studies, look at exposure in patients. I'm going to mainly focus on the other 2 areas, which are therapeutic drug monitoring and the work that we do in paediatrics on clinical trials where data is generated, which allow us to hopefully put forward more sensible dosing regimens for groups of patients, which we class as kind of particularly challenging patients to treat. So these may be preterm infants, they may be neonates, they may be anephric patients, obese patients, patients receiving high-dose chemotherapy, for example, anything outside of the kind of standard dosing regimens for these patients, where we either carry out therapeutic drug monitoring, where we actually modify dosing based on individual patient exposure. We've got some nice examples there, but also studies where there's just very limited pharmacology data, where we can generate data and therefore propose more rational dosing regimens. So the approach that we have in terms of our funding, we have central funding from Cancer Research UK, which is for the unit and funds a few people in the lab in terms of the staff. At any one time, we probably have a dozen clinical trials that we're involved in terms of measuring pharmacokinetics. We also do some pharmacodynamics studies, things like circulating tumour cells with Alistair Greystoke and David Jameson in the lab. But the approach to funding is generally to try to get relatively small pots of money for each of the clinical trials we're involved in. So anything from kind of sort of 20, 30,000 up to 100,000 will allow us to basically support the trial in terms of having samples sent from either national centres or sometimes European centres allows us to support the analysis of those samples and the reporting of the data. And that's a combination of kind of academic groups working with Cancer Research UK, the Centre for Drug Development, and also some pharmaceutical companies. These tend to be relatively small pharmaceutical companies who are often kind of spin-out companies from universities. So just a few slides in terms of some assays that we've recently developed for the phase 1 work that we do. When we have a clinical trial that's going to be opening, we normally get access to the drug maybe 3 to 6 months before the clinical trial opens, and we're asked to work up an assay according to the kind of EMA and FDA guidelines. So this is a list of some of the drugs we've worked with over the last few years. It's got a slide on a few of them. So MOV18 these are all in adults at the moment. We had a few paediatric phase 1 studies, but they're fairly few and far between, unfortunately. So MOV18 is a first-in-class IgE antibody, which has high affinity binding to tumour cells in tissues. You can see this bottom left-hand corner, the graph shows this patient cohort, which is increasing doses, starting at very low doses. We actually started at a 70 microgram dose, so very small doses, due to kind of concerns over the safety for a first-in-class drug. But you can see quite a nice correlation between the exposure of the drug level and the increasing dose with the increasing patient cohort, and again shown with the individual PK profiles there. So that was an example of an ELISA type assay. Most of our work is done with LCMS type approaches. And whereas we used to have fairly standard small drug molecules coming through, we now have a range of kind of weird and wonderful drugs which are kind of coming to market. So this is a bicycle drug and this novel cyclic peptide drug conjugate shown here, which is basically a delivery molecule with this kind of toxic DM1 payload, which is targeted to the tumor cells. And again, we have a similar pattern here with increasing dose level. You can see increasing exposure to the drug. This final example is actually a study that we ran with Neil Rajan at the university, who works on these SILT defective tumours. These are the drugs that he was looking at was a TRK inhibitor, and it was a topically administered drug. And what Neil was interested in was how far the drug penetrated into the tumours. So we kind of took essentially sort of like punches from the tumour, and they separated different levels of depth into the tumour. And we were able to work up an assay and to measure these levels. And you can see that in this patient here, 1007, for example, you've got a higher concentration of tumour in the top level, and then it's dropped slightly in the middle level. And then as you go deeper into the tumour, you've got less drug penetrating. But for some patients, there was almost no penetration of the drug into the deeper tumour level. So an interesting study where rather than looking at systemic drug concentrations, we looked at drug concentrations following topical administration. So the work that we do in paediatrics, the group has been working in paediatric oncology for over 20 years. We've established a really good relationship between centres across the UK who have got a real interest in doing this work. So there are 21 primary treatment centres in oncology across the UK, and we've worked with all of these centres at some point, but at the moment we're working with kind of 18 of these centres where they have research nurse staff available who are able to take samples in a kind of standardised and controlled way. So we've analysed samples from over 1,000 patients across many studies. And over the last 5 years in particular, because we've been running clinical trials where we've obviously been asking centres to collect samples for particular drugs for particular tumour types, we've increasingly got in a position where clinicians, for some of the challenging patient groups that I mentioned at the start of the talk, they're really kind of wanting to know if a particular dose is going to give them meaningful drug concentrations. And increasingly now they're kind of sending requests, and we get requests on a weekly basis from centres asking us to measure drug levels for particular patients to see if they're in the right kind of range, if they're hitting the right kind of exposures where we'd expect to see the tumour cells targeted. And this photo here is from a recent training event that we held with research nurses from around the UK. So I think when we kind of started this work, we very much looked at paediatrics versus adults, and it's really only in the last probably 5+ years that within that paediatric group we've really started to focus much more on individual groups. So that may be preterm infants and neonates, and looking at the real differences in how drug disposition is different between those very young patients and teenage patients, for example, as opposed to simply running paediatric studies versus adult studies, which historically very much focused on teenage patients compared to adult patients because teenage patients were were easier to study, were easier to collect samples from. But actually, it's really the preterm infants and the neonates, certainly in the first year of life, where we would expect to see bigger differences in drug handling. Sorry, got a slight delay on the... Okay, sorry. So this is a summary of the studies that we've got open at the moment, a range of different tumor types, Ewing's, sarcoma, ependymoma, brain tumors, the AML My Child trial. We're looking at a range of drugs. We're also looking at the selumetinib dexamethasone study, which is in pediatrics as well as adults. The two studies I'm going to focus on today, because I think the most relevant as an example of how clinical pharmacology studies can be used to benefit treatment in pediatrics more generically, are this study, the therapeutic drug monitoring study mentioned here, and then this 13-cis-retinoic acid liquid formulation bioavailability study, which has just completed recruitment. So the first story is this one with 13-cis-retinoic acid. This is one of the first research areas I was involved in when I moved to Newcastle many years ago. So 13-cis-retinoic acid was introduced to the treatment of high-risk neuroblastoma patients when it was shown that it was beneficial from a big US study. We carried out an initial pilot study to look at the pharmacokinetics, and it looked like there was a massive variability between patients in terms of the exposures that were observed following standard dosing in patients. And I think from previous data, we knew that there was a lack of benefit of low-dose 13-cis-retinoic acid, which suggested that dose was important. And also, this drug is given over a 6-month period. It's given as 2 weeks on treatment, followed by 2 weeks off treatment for a 6-month period. So we knew that if we were to kind of carry out therapeutic drug monitoring studies in here, where we look to get the dose right for the individual patient, we had quite a wide window to get that right across 6 cycles of treatment across a 6-month time period. So this slide summarizes sort of close to 20 years of work where we carried out this initial study, showed this massive variability in exposure following standard dosing. From a scientific perspective, obviously, we were interested in things like pharmacogenetics to see whether there are genetic differences, why there may have been differences in exposure between patients. So we looked at some of the CYP enzymes, which are involved in the metabolism of the drug, but there didn't seem to be anything particularly interesting that came up there. The kind of neuroblastoma community very interested in the results showing these large differences, particularly because they were concerned that some of the patients may be receiving subtherapeutic drug concentrations. So we moved on to carrying out a therapeutic drug monitoring study where on cycle 1, we measured individual drug exposures, and we then modified dosing in individual patients where they had what were classed as subtherapeutic or on the lower side plasma concentrations. So these 2 figures just here show these patients who are highlighted with the red arrows. You can see they've got plasma concentrations below what was seen as a cutoff of around 2 micromolar. So we've got 4 patients here where following standard dosing of 160 milligram per meter squared for children above 12 kilograms or 5.33 mg per kg for children less than 12 kilograms, they clearly had lower exposures to the drug. So what happened in those patients was simply that the dose for those patients was tailored. They had an increased dose on cycle 2, and that then led to obviously a more consistent drug exposure across the patient cohort. So following the publication of the data from this study, the dosing regimens were changed. So this 5.33 mg per kg dosing that was used in children less than 12 kilograms was removed. There was never any real kind of good scientific rationale for that, but there seems to be a default mg per kg dosing, reduced dosing in the younger patients. This is not a drug that's got lots of side effects. So there was always a kind of question mark whether you needed to reduce the doses in those patients. So following the publication of this data, the doses in all patients were increased to at least 160 milligram per meter squared. The other thing that we discovered, and this is something that had been flagged up by the centres, was that many of these patients are kind of 1, 2, 3 years of age. They actually can't physically swallow the capsules. These are quite large capsules that are given to the patients. So the research nurses or the parents have to essentially extract the drug, sort of snip the capsules and extract the drug and give it to them, normally on a teaspoon with maybe yogurt or chocolate mousse or a range of different weird and wonderful approaches. So again, it wasn't surprising that for these patients, they were getting much lower exposures. So for patients who aren't swallowing the capsules, the dose is increased to 200 milligram per meter squared. So this data was published, and these changes were made to children being treated with this drug in high-risk neuroblast setting across Europe. But it didn't solve the problem that we've still had essentially a drug formulation which wasn't really fit for purpose. It wasn't really, very practical for the majority of patients. So we managed to get a grant from the Wellcome Trust and the Department of Health with Leicester University and the Nova Pharmaceuticals, a pharma company down in Leicester. And they worked hard to develop a novel formulation of 13-cis-retinoic acid, which is a liquid formulation, a syrup formulation, which can be given to children on a spoon. And last year we carried out this bioequivalence study where we showed that the new oral formulation led to at least comparable, if not better, exposures than the capsules. And this is this figure here, if you can see my marker. This is a classic what we see with the capsules, that for a patient, this is day 14, this is day 1. But actually on one of those days, just for whatever reason, that the capsule wasn't swallowed appropriately or wasn't administered properly. So they almost have essentially a flat line. So on that particular day, they had clearly very, very low drug concentrations. Whereas with the new formulation, we're getting consistently high exposures pretty much across the board in all patients. So I think a really nice example of where by running clinical pharmacology studies, we can improve the way that drugs are administered to patients. We went through a series of doing therapeutic drug monitoring and real-time modification, but that also led to changes to dosing regimens and now to the formulation of the drug. But it also shows how these things take a long time to actually get these clinical trials up and running, get the ethics, get the data generated. It takes many years to make these changes. So we spend a lot of our time developing assays to measure drug levels, and these are all developed according to EMA FDA guidelines. It means that we have a whole range of drugs where we have assays available. So in terms of therapeutic drug monitoring, when centers have patients who are, they're not too comfortable with the current dosing regimens and they want to actually look at what the exposure to a drug is, for the majority of drugs, we have assays available, or we can kind of work up assays for drugs where there's going to be an interest. So the idea behind therapeutic drug monitoring, sort of very simply, is that with all drugs, you're going to have a range of concentrations. In terms of a standard dose of drug will lead to high exposures in some patients, which is determined by measuring drug concentrations in the blood or in the plasma. But also it will lead to, in some patients, it will lead to very low drug concentrations. So these patients are ones that you'll probably kind of select out. If you're giving 4 cycles of chemotherapy, you give your first cycle, you get excessive toxicity, then you're going to drop the dose of drug for cycle 2. But in an ideal world, it would be nice to be able to do it before you saw the side effects. But the area where therapeutic drug monitoring becomes really handy is these patients who are essentially getting drug exposures which are below the therapeutic window, where you're unlikely to see benefit of the drug, or they're potentially going to be the first patients who are going to relapse during treatment. So therapeutic drug monitoring is really the only way to pick out these patients and to say, okay, we need to increase the dose in these patients to bring them up to the therapeutic window. So I've mentioned this already, kind of which patients are we interested in? We obviously do have our drugs, which we've got a research interest in, which we've worked on for many years, but it's more down to the patient groups than the drugs. So I think in all of these patient groups, high-dose chemotherapy, you've got poor prognosis patients, you're giving high-dose chemotherapy, you're going to have side effects, but you don't want the variability which leads to some patients having really excessive toxicity. Infants and very young children, from our experience, it's really hard to predict drug exposure for a whole range of drugs. Anephric patients, obviously for renally cleared drugs, that's very challenging. Patients with hepatic impairment, and then obese and or malnourished patients where we see kind of marked differences in drug disposition. So this is obviously, we're getting in the Western world now, we have a higher percentage of obese patients where drug handling is going to be different. We've also done some interesting studies looking at differences in pharmacokinetics by patients treated in the UK as compared to patients treated in Malawi, for example, and showing quite marked differences in drug disposition. And we're bearing in mind that the dosing regimens that are used in some of the developing world are actually based on Western populations, so it may not be particularly appropriate. So there are a whole range of reasons why we may see marked differences in drug disposition, in drug handling, in preterm neonates and in infants, children in the first few months of life. For example, changes in the ontogeny of cytochrome P450 enzymes, which are involved or responsible for the metabolism of the drugs. Quite marked changes in liver function, kidney function in terms of rapid changes in GFR in the first weeks and months of life. And even simple changes like percentage body fat, percentage body water in babies are different than older children, which again are going to impact on the distribution of the drug around the body. And I've kind of touched on this already, but from a pharmacological perspective, our kind of obvious question is, for the majority of children less than a year of age or less than 12 kilograms, you're giving markedly lower doses of drugs to these children. And the question is, why are we doing this? Is it because we think these children are much more susceptible to the side effects? Or is it because we think that the drug disposition is going to be very different? So the rate of clearance of the drug is very different in these children. And to an extent on the pharmacology side, we can kind of answer this question. We can look at whether there are marked differences in the drug handling in these very young children. And hopefully that will allow us to, for some drugs, potentially allow us to suggest more rational drug dosing, as we did with the 13-cis-retinoic acid. And I think the other issue here is that you've got these very artificial cutoff points for children. So, less than a year of age, above a year of age, you've got quite marked differences in dose. It could be 25%, could be 33%, could even be 50% dose difference. So one of the most common questions I get from clinicians is, I've got a patient who on the last cycle, they were just below 1 year of age or they were just below 12 kilograms. We dosed them according to the reduced dosing, but now the patient is above. And actually, I must have worked this out wrong because the dose is 50% higher, but actually that is the way that the dosing works. So again, just trying to generate some pharmacological data, which hopefully will allow us to kind of answer some of those questions and as I say, propose maybe more rational dosing regimens. So the drug carboplatin is a good example. We've looked at this drug for many years. It's a really good example of a drug for therapeutic drug monitoring because we know that historically studies from Newcastle and other groups have shown that if you measure exposure in terms of the plasma concentrations of the free drug, there are really clear correlations between the exposure, the AUC, and the toxicity and response that's seen in patients. So just to give you an idea of where, particularly patient groups where therapeutic drug monitoring is particularly beneficial, this shows treatment with carboplatin across 3 cycles of treatment. So these are 2 children in the very first few weeks of life. So course 1 is 2 weeks of age, course 2 is 4 weeks of age, and course 3 is 6 weeks of age. This is the clearance of the drug, the rate of clearance of the drug. So for both of these patients, the difference between week 2 of life and week 6 of life is approximately a doubling in clearance of the drug. So if you give the same dose of drug on cycle 3 as on cycle 1, you will have about half the exposure, about 50% of the exposure. These traditionally carboplatin will be dosed like most drugs based on body weight. So difference between a two-week-old child and a 6-week-old child, you'd maybe increase the dose by 10% because of an increase in body weight. But actually, you need to double the dose because otherwise you're going to get a much lower exposure. So these are patients where it's just really difficult to predict without doing therapeutic drug monitoring. And this graph in the bottom left-hand side gives a patient where we did therapeutic drug monitoring on cycle 1, which is shown in blue. They actually had an overexposure. We had to reduce it. But you can see that you were giving about 75 mgs of drugs over the 3 days. So 2 weeks later, the second cycle was given. We thought, okay, 25 mgs per day should be fine. But we carried on doing the real-time adjustment and measurement. And actually, because the renal function had improved rapidly in this patient, it meant the drug was cleared more quickly. This patient actually had to have quite a dose increase on day 3 of treatment in order to hit that target exposure. So we've now got dosing guidelines. Carboplatin is now, therapeutic drug monitoring is now the kind of gold standard for any child less than 3 months around the UK. We have national guidelines through the Children's Cancer and Leukemia Group. And we do these patients now on a weekly basis for centres such as Great Ormond Street, Birmingham, as well as kind of Newcastle. If I've got another few minutes, I've got a very quick case study. Is that okay? Antonio, do you want me to go to the end to leave time for questions? Okay, so last couple of, this is just an example of another drug where, very similar to carboplatin, we had to kind of make marked changes to the dosing over the first few weeks of life. This was a patient with hepatoblastoma, born at 37 weeks. Tumor biopsy was confirmed the diagnosis of hepatoblastoma. The standard dosing was 1.6 mg per kg, but essentially we measured pharmacokinetics over 6 courses of treatment between week 2 of life and week 17 of life. So blood samples measured at 3, 6, and 24 hours. And very like carboplatin, we saw that the clearance of the drug markedly changed during the first weeks and months of life, which meant that the dose on each cycle essentially had to be increased to account for this change in GFR. So we started at 1.6 mg, we had to increase up to a dose of 2.5 mg to maintain the AUC that was seen. And again, most of these patients, as long as we hit the exposure right, these patients have a pretty good chance of having a good prognosis and a good response to treatment. So an example with another drug, with cisplatin in this case, where, again, therapeutic drug monitoring has been shown to be beneficial. So we now have a clinical trial which is ongoing. We are now just over a year into this trial, which allows us to kind of roll out this therapeutic drug monitoring approach more widely. It gives us financial support. It's funding from the NIHR Research for Patient Benefit funding stream. So it allows us to support these centres in funding the transport of the samples and to Newcastle and the analysis of samples. So you can see we've got over 50 patients now, a whole range of drugs. So most of these are kind of infant studies, but we also have some patients maybe on high-dose chemotherapy, or patients where they experienced excessive toxicity, where they had to have marked dose reductions, and they want to see that exposures are still reasonable. So I think during the course of this 3-year study, we should generate some really interesting data in neonates and infants in particular, where we can have enough data on a reasonable number of patients to allow us to look at what are the key factors that impact on exposure and allow us to maybe put forward some more rational dosing regimens. I'll shoot these slides. I'll just go to the summary because I think we're short on time. So just to summarize then, we have a kind of healthy portfolio of clinical pharmacology trials being carried out in Newcastle. I think therapeutic drug monitoring is much more widely used across other specialties, but I think in cancer, we've certainly increased in the use of it in the last few years, and centres are very much on board with this. Potential for generating data which I think can really impact on patient treatment, and that 13 cis-retinoic acid, I think, is a nice example of, although it may take a long time, we can actually generate data which helps with patient care. And that's just to mention then the people who haven't updated that slide. It still says the Northern Institute for Cancer Research, but they're the people who are involved in the university and also at the RVI. So thank you. Happy to take any questions.
Brilliant, Gareth. I think that's a beautiful overview of kind of the work of your group, but also the role of clinical pharmacology in not only supporting and facilitating drug development, but also kind of inform clinical trials and actual dosing in patients. I'm just looking at the audience. So clearly the audience listening to you today will be a very varied background. Now, although the examples you've given are mostly oncology related, if there are people in the audience who are interested in drug monitoring, as you've explained, in a non-oncological context, where could they go?
That's a good question. I think there will be. I think for a lot of drugs where therapeutic drug monitoring has become standard of treatment, there will be in-house assays. So something like valproic acid, sodium valproate for epilepsy, and it's been used now a little bit in oncology. There are assays available through the hospital labs essentially. For other drugs where it's maybe a bit more experimental or it's a newer area, I think probably universities where they have a research interest are probably the places to go. So I would certainly be happy for people to contact me, and I could probably put you in the direction of people who with an interest in the area.
Great, thank you. Are there any other questions from the audience?
Oh, can I ask a question, Gareth? Yeah, that was a very nice talk. I mean, we use therapeutic drug monitoring in kidney transplants all the time, and then actually, it's quite nice linked to your talk because it just struck me that in pediatrics and probably in adult medicine as well, we look for side effects by measuring like using these liver function, etc. But we never really look at how effective, whether we're actually reaching those levels. So in your oncology patients, the graph you show shows something like 30% weren't actually reaching drug, where you need the drug to be. Is that quite typical?
Yeah, I think that was for an example in high risk neuroblastoma. I think that particular drug, it had, as I mentioned, there were a number of issues with the way that the physical kind of way the drug was administered, which were challenging. You normally see probably commonly 3 to 5 fold variability. So I think there are certainly plenty of drugs both in pediatrics and adult where it's kind of well known that you've probably got a significant percentage of patients who are potentially underexposed, underdosed. It's just that the practicality, certainly in adult medicine, if you go to drugs such as 5-FU used in breast cancer patients, just the numbers of patients, and the cost of analysing samples. Whereas I think on paediatrics we're in a fairly kind of bit more of a comfortable position because the numbers of patients where therapeutic drug monitoring is kind of desired or requested, it's manageable, it's doable. I think there are lots of drugs where scientifically you could say we really should be doing TDM and increasing or decreasing doses, but it's through the NHS and it's just the cost, isn't it? That it's just not feasible, I think.
Yes, and do you feel that in a few years' time you'll be offering a national service where people just send samples to you for X, and then you give them a result, in a few days' time? Because that sounds like where it's heading, isn't it?
Yeah, absolutely. So the rationale behind getting the NIHR Research for Patient Benefit treatment was really because it got to the point where we were having samples sent to us, requests for TDM on a weekly basis, which alongside our research study was just really hard to actually be able to kind of turn around the samples in time. So we realized we were going to need some funding and a dedicated person to work on the study. So I kind of I dislike the use of the word kind of like a service. People kind of say, "Oh, well, pharmacology is providing a service," whereas I very much see it as research. But the NIHR RFP was essentially that. It was essentially to give us a three-year period of funding to allow us to roll out the TDM service across all centres and so around the UK. So the challenge we now have is I think that we've got to the point where the centres now are almost becoming reliant on this. If they have a 2-week-old patient with a particular drug, they're going to want to do the testing. So we're fine for the next kind of year and a bit. But once that funding stream comes to an end, it's then what we do. And I've always kind of been resistant against the idea of any kind of kind of spin out company or anything. We want to keep this affordable and free of charge or funded through sort of charities or research funding. But it's a question of how we can put something in place that's a bit more sort of long term, I guess. But it's a challenge to come, I think.
Excellent. Do you have any other questions from the audience? You can put your hand up, or the virtual hand. I think that's probably it. Yes, great. Well, I think that's been absolutely fascinating, Gareth. And then it's lots of food for thought. And I think maybe in the future we'll have centres around the country, labs around the country where you ask for a MMF level for a Crohn's patient who's not responding to their treatment, etc. And I think that's great. So thank you very much, everyone. That's the last talk we have before the summer break, and we'll love it if people can join our organising group, and we'll be in touch. And have a great summer. And thank you again, Gareth.
Thanks very much.
Round of applause. Thanks, everyone, and thanks, Gareth.